Thank you. I'm Dr. Curzon. I'm currently a fourth-year resident at the University of Tennessee, Knoxville. As Dr. Rusevich said, I'm going to be speaking on breast cancer in elderly patients 70 years and older, University of Tennessee Medical Center at Knoxville, 10-year experience. This is kind of a companion study to the one that Dr. Snyder just talked about in the younger patients. So by way of introduction, we know that the incidence of breast carcinomas increase with age, with about 30% of new carcinoma cases being diagnosed in patients greater than or equal to 70 years of age. However, there's still a paucity of data on how breast cancer biology influences the outcome in these elderly patients. There have been a few studies that showed that breast carcinoma in this elderly population had a higher probability of favorable tumor biology, that being hormone receptor ER and PR positive and being HER2 negative or node negative. However, in spite of a higher probability of this traditionally favorable tumor biology, about 50% of the deaths from breast cancer are in this older population. So in our institution, we've shown in two previous studies looking at overall survival of Caucasian women in our area, that an ER, PR, and HER2 status was not predictive of overall survival in this population, but that TNM stage was predictive significantly. So the objective of this study was to assess whether ER, PR, and HER2 subtype, as well as TNM stage of invasive breast carcinomas, had any significant impact on the overall survival in this elderly subcohort of patients that are older than 70 years. So we looked at this cohort of 232 elderly Caucasian female patients in our institution during a 10-year study from the interval of 1998 to 2008, when controlled for ER, PR, and HER2 status, TNM stage, and grade. And these were analyzed by a Kaplan-Meier curve as well as the multivariate Cox regression analysis. And the last day for follow-up was in August 2013. So there were the 5 ER, PR, and HER2 subtypes that were classified per the 2011 St. Gallen International Expert Consensus recommendations that have already been talked about by Dr. Snyder and Dr. Rusevich. These were subclassified further into 3 subtypes. Those traditionally considered favorable, being ER, PR positive, and HER2 negative, and then traditionally considered unfavorable, being the HER2 positive, and then lastly the triple negative. So this is kind of a breakdown of all the patients we had and how we broke it down. So there were 232 overall, broken down into the 5 St. Gallen classifications. As you can see, the majority were on the luminal A or luminal B, being 76% total in these traditionally favorable subtype. And then there's the luminal B HER2 positive and non-luminal HER2 positive like that were traditionally unfavorable, that were 12%, and then the triple negative, we had 11.2%. So this is a table kind of breaking down all of our data, looking at ER, PR, HER2 frequency, the age. We can see the average, they were all older than 70, averaging in the mid to late 70s. The histologic type, they were all most commonly invasive ductal carcinoma. The tumor size, you can see it averaged around 20 millimeters for all of these. As well, if we look at the survival months, they look fairly similar, except it was kind of surprising. In the luminal B HER2 positive, we see a bit of an increased survival at 101.1 months compared to the others. So of our results, the majority of our patients, 76.8%, were in this favorable breast carcinoma subtype, being ER and or PR positive, HER2 negative, subdivided, as we saw in that graph, into luminal A and luminal B, HER2 negative like. And then 23.2% of the patients were in the traditionally considered unfavorable subtype, being the HER2 positive subtype, which was subdivided into the luminal B, HER2 positive like subtype, and HER2 positive non-luminal subtype, and then finally the triple negative subtype, which were 11.2%. So looking at a Kaplan-Meier curve, looking at the survival months, you see we followed it up to about 170 months, looking at cumulative survival. This was stratified by ER/PR and HER2 subtypes, again, into these three groups: the favorable, the traditionally unfavorable, which were HER2 positive, and then the unfavorable, which is a triple negative. And this analysis showed that ER/PR and HER2 subtype had no significant impact on overall survival. And then in the Cox regression analysis, here we're looking at cumulative survival with the ER/PR and HER2 groups, broken again into the three subtypes, the favorable being ER and or PR positive, the traditionally unfavorable, HER2 positive, and then the unfavorable triple negative. And again, this showed that ER/PR and HER2 subtype were not statistically significant for the prediction of overall survival. But when we looked at the same Cox regression analysis, plotted out TNM stage, we found that TNM stage was a significant predictor for overall survival in the higher stages, stages 3 and 4. However, there was not a statistically significant difference between TNM stages 1 and 2 in this analysis. And when it was worked out for grade, it was also found that grade was not a significant predictor for survival. Another thing we looked at quickly was the treatment in this elderly population compared to the young group that Dr. Snyder spoke of. And we saw that the majority of patients underwent a modified radical or total mastectomy. Similarly, there was 61.6 versus 67.9% in the younger population, so it was similar. However, post-surgery treatment was decreased in this elderly population. We see that 32.3% had radiation compared to 46.1% in the younger group. Only 21.4% received adjuvant chemotherapy compared to 82% in the younger population. And then 57.2% of the ER-positive patients received hormonal therapy compared to 76.5% in the less than 40 age group. So as a summary, we observed a trend for overall survival in HER2-positive breast carcinoma patients traditionally considered as unfavorable over patients in the favorable subtypes. So looking at, as we saw in that graph, here this traditionally unfavorable subtype, the green line there was that HER2 positive. So it did look different than the other groups. However, it did not reach a statistical significance. And in that analysis, no ER/PR or HER2 subtype was significantly predictive of a better overall survival. We did find that TNM stage was significantly predictive for survival in the advanced stages, again, 3 and 4. These results are similar to our two previously published studies where ER/PR and HER2 status also were not predictive of overall survival in this Caucasian breast carcinoma patients. And this was irrespective of the classification system used, while TNM stage was predictive of overall survival. So some possible causes for the results from our previous and current studies in this greater than 70 years subcohort that could be attributed to the composition of our study population, in that we were only looking at the Caucasian patients in our area. Also the type of ER/PR and HER2 classification system used, and that we're looking at the St. Gallen breast carcinoma subtypes versus others that may be used. And also the time period of the study in that 10-year period of 1998 to 2008, where screening, diagnostics, and treatment for breast carcinoma patients had improved significantly compared to prior time periods. Also, in at least 2 other different studies, some elderly patients with an unfavorable triple-negative breast carcinoma phenotype were shown to have a better or same outcome when compared to the corresponding younger cohort. And better survival was seen in spite of lower use of chemotherapy and radiotherapy in elderly patients, as we also had observed in our population. So this raises the possibility that the same traditionally quote, unfavorable breast carcinoma subtypes could exhibit a different tumor biology in younger versus older patients. And that would be something interesting to try to look into. So just an overall conclusion, again, our study on this elderly Caucasian female breast carcinoma patients showed that ER/PR and HER2 status was not predictive of overall survival, while TNM stage was significantly predictive for survival. And these results are similar to our previously published studies on Caucasian female breast cancer patients in the East Tennessee area. Some standardized treatment recommendations for this older population are also less strictly defined than for other age groups, and we thought that some further studies, perhaps in the setting of a clinical trial, may be warranted and could possibly reconcile and stratify the given therapy with outcomes. Thank you.
Thank you very much. Here is your certificate. Now we will